Sierra is the chief of hip and knee division of Department of Orthopedics at Mayo Clinic, Rochester, United States. And he has a huge experience for complex hip and knee reconstruction. He has 17 years of peri-acetabular osteotomy and hip preservation, and it's a great opportunity for our community and for our country to get benefit from his experience and listen first from him. He will give us a short seminar about his technique for peri-acetabular osteotomy and simultaneous hip scope. Then we will get 10 minutes of questions with his permission. And Dr. Sierra, thank you again. Thank you so much.
Well, thank you, Dr. Hapa. It's really a pleasure for me to be here with you today. As Dr. Hapa expressed, it's peri-acetabular osteotomy is certainly an operation that I do a lot of. I've been doing it for more than 15 years, and I was trained by Reinhold Gans, Professor Gans, how to do these. And it's one of those operations that I hold very dear to my heart, as it is a very tough operation. Obviously, it's got a very significant learning curve. So when I have these opportunities to be able to teach what I do, it's certainly exciting for me. So thank you very much. I will go ahead and share my screen with my talk. And the purpose of this talk is to describe to you the combined hip arthroscopy and peri-acetabular osteotomy for hip dysplasia. I have no conflicts specifically with this talk. So with hip dysplasia, the aim of surgical treatment is to really try to restore the anatomy as close to normal as possible. And although some of you might say, well, there are some circumstances where a hip arthroscopy alone may be an option, with patients that truly have dysplastic hips, I think that should be our ultimate goal, to really try to make the anatomy as close to normal as possible. And there's only one way to do that, is with some form of osteotomy. Although there are a number of osteotomies that have been described for this, my preferred technique is the peri-acetabular osteotomy. So when we think about hip dysplasia, and we have to think why the hip hurts. And so obviously with hip dysplasia, a lot of our patients focus on the labrum. My labrum hurts, but they don't really understand the underlying cause of their damage. So we know that some people will have labral tears, but some people will have cartilage damage as well. And I think that a lot of people may hurt mainly because of the overload of the rim of the uncovered area, which will eventually lead to this damage to the chondrolabral junction as shown here. But for example, in this image that you were seeing here, there is really no tear. It's simply the rim overload and the beginnings of the damage that eventually causes pain. And some patients will have pain also related to instability, and that leads to tendinopathy because the muscles are overworked because of trying to maintain some stability within the hip. And obviously, how these patients present differs mainly based on their age, but most importantly on the severity of their dysplasia. And I'll just show you here 5 different patients that are less than 50 that have presented to my office with different symptoms and radiographic features. On the right hand side, you can see patients with more severe forms of dysplasia now that have osteoarthritis, and then some young patients that have more severe hip dysplasia. So to start this presentation, I think it's important again to reemphasize that to me, the best treatment for dysplasia is a peri-acetabular osteotomy, especially for the young patient less than 40 that has symptoms related to dysplasia, that clearly has radiographic features associated with hip dysplasia, and that has preserved acetabular cartilage. So that patient is the ideal patient for a peri-acetabular osteotomy. And we can talk about other circumstances where we would use a PAO, but for dysplasia, this is what I would recommend. So in order to put into context then what can be done from an arthroscopic standpoint, I think it's important to discuss four things. Number one, is the problem that's in the hip joint necessary to be worked on at the time of surgery? Number two, why do it through a hip arthroscopy and, for example, not with an open approach, which can be done as well? Who needs to have this done? And if we are recommending, who is the best candidate for that? And the fourth point, and we'll talk about it as well, is how I do it. So first with the findings. So these are two papers that were published several years ago. The first one on the left-hand side was by James Ross and John Clohesi, where they looked at patients that came in with mechanical symptoms. So patients that were complaining of catching, locking, popping, the typical symptoms that people with some dysplasia. And they documented that about 2/3 of these patients had a labral tear. 56% of these patients did not have treatment of their labral tear. They only treated about 40% of these patients. So even patients that have mechanical symptoms, half of them to 2/3 really don't have anything in their hip. So mechanical symptoms doesn't really correlate with a labral pathology, and this is important. The second study here on the right, very similar. They documented the prevalence of labral and cartilage damage. They did not do any type of surgery at all for this problem. And they only found that the biggest predictor of progression after the peri-acetabular osteotomy was actually damage to the femoral head. So again, the damage of the labrum was not correlated. Damage in the cartilage didn't correlate. So again, there are a couple of studies here documenting the incidence of these findings. So is the intraarticular work needed? So there is data to support that maybe it should be treated. And I'm talking about labral tears. Why? Because we know, based on even Reinhold Ganz's original papers, if the patients did not have a labral tear, they had better results. There are also some studies that have shown that an osteochondroplasty to the femoral head-neck junction is protective compared to not doing anything. And there are some, obviously we can talk about this in our discussion. Obviously there are some good things and bad things about doing that, but the data does support that if you do something to the to the head and neck junction, it might be of benefit. The data that refutes this is that not everybody will have pain, even if they have labral tears. So Kyle Sabali, who's a surgeon in Denmark, he does about 200 peri-acetabular osteotomies a year. He never does a hip arthroscopy. And he's published work saying that about 25% of his patients might need a subsequent surgery, but it really doesn't change much the results. And so whether the morbidity of another procedure at the same time, is it really worth it or not? What we do know for sure is that a hip arthroscopy is better than open arthrotomy for these. So this is a paper by John Redmond and Benjamin Dome showing that the ability to visualize with a hip scope is much higher than when we used to do it open. So you can see here the differences between acetabular and labral, chondral, and labral pathology was much easier to see with a hip arthroscopy than with an open exploration. So we could pretty much summarize that a hip arthroscopy over an arthrotomy provides better diagnosis and management. It gives you the potential for aborting the PAO. That's happened to me maybe 3 or 4 times where I get in there and I was like, oh my God, this is too much damage. We're not going to do the PAO. And there are some downsides of opening the joint up. When I used to open the joint, we would have to take down the direct head of the rectus, which you could likely do today. I don't think you have to do that, but there is some morbidity with that. So a rectus sparing peri-acetabular osteotomy is today, I think, a more acceptable procedure. And there's less risk of heterotopic ossification with hip arthroscopy compared to an arthrotomy. The question is, does it increase complication rates? Adding a hip arthroscopy to a PAO. We wrote a paper in 2019, and we clearly showed that it was longer to do when you combine it, of course. The majority of times we were doing something intraoperatively. You can see the mean surgical time was about 210 minutes. I think we can do these a lot quicker today. But it is a very comparable from a complication rate, very comparable to a PAO alone. That study results were compared to a previous study that was published by our same group. Our results published in JBJS 2014, and we showed that really adding the hip scope to the PAO actually did not increase the complication rates, even though these patients were undergoing a little bit longer operation. So the complications that we saw when we did the hip scope and the peri-acetabular osteomy, the majority were very low-grade complications. Lateral femorocutaneous nerve dysesthesia was higher when we combined the hip scope, and I think it probably has to do with a combination of traction and the pull because you're leaving the rectus. And there was a higher incidence of heterotopic ossification in the previous study compared to this one. So adding the hip scope does not add the risk of heterotopic ossification, but it also biased by the fact that we're probably more aggressive with our prophylaxis. We did not see increase in the grade 3 or 4 complications. We're talking about reoperations, revisions, etc., with the hip scope. And we did obviously find that increasing age was associated with more complications. So, okay, so now I'll move on to, so when I started doing a combination of hip arthroscopy and peri-acetabular osteotomies, this was in September of 2013, and I performed 73 consecutive peri-acetabular osteotomies with hip arthroscopy from September 2013 to February 2015. So everybody that came through my door, I put in the hip arthroscopy, the hip scope at the time of the peri-acetabular osteotomy. So there were 48 patients with DDH or dysplasia, 13 patients with retroversion, and in dysplasia, I'll list this out. We really found that, and this has not been reported previously in this way, that the damage that occurs in the labrum is a continuum. So it starts from a large labrum, which is very typical, and I'm going to show you some videos of that, and then it progresses with the severity of the dysplasia as well as the severity of the disease. So it's very rare in these cases to see a completely normal labrum. And what I mean by that is, I mean, this labrum that you're seeing here, you would say probably has a little bit of hypertrophy, maybe a little bit larger. There's a little bit of early debonding, but that labrum looked pretty good. There's no redness, there's no tear. It looked pretty normal. That is extremely rare. And I only saw that in one of those hips that I did it was more common to see this. This is a very large hypertrophic labrum where you can see the continuum of the labrum with the cartilage. It's very large and bulbous, so very hypertrophic, but there's no tear of the chondrolabral junction. And I saw this in about 17 of those hips. Then we have the patients that have very similar imaging or for arthroscopic views, but they have a very large and hypertrophic labrum, but also with a tear of the chondrolabral junction. And we saw this about in the same number of hips. And then after that, that's when they go bad. This is when we start seeing hypertrophic labrums that have tearing, but also the beginnings of very severe damage to the rim. These patients would be some that I sometimes would abort, but sometimes we just went ahead and did the peri-acetabular osteotomy despite the damage. Obviously, there are some damages that are a lot worse, and this is one patient of the 3 where I had to abort completely the operation. You can see the severity of the damage as well as the eventual microfracture that I did for that patient. That was their only treatment. I eventually replaced her hip within 6 months of this arthroscopic procedure. So if we summarize these patients that had dysplasia, where I did the arthroscopy, I did some form of treatment inside the hip in all the patients except that patient that had completely normal hip arthroscopy. In 20 of these hips, I did a thermal chondroplasty, which is essentially using that wand to kind of clean things up. But there were 27 hips where we actually performed more significant fixation of the labrum or chondroplasty of the acetabular rim. If we look then at the patients where I did not do much, where I simply did that wand treatment, these patients were clearly younger hips. They had similar duration of symptoms. They had less severe dysplasia. If you can see in here, there was no difference in their mechanical symptoms. So I would say that maybe those 20 hips where I did very little work, those patients might be the ones that you may not have to think about doing hip arthroscopy. So the question is, how do I identify that patient preoperatively to make that decision? And the problem is that we don't have a very good way to diagnose that. Why? Because age, maybe you would say that patients that are older than 25 had a very high, much higher rate of needing something done, but it was also correlated with how long their symptoms had been present. So mechanical symptoms, if a patient tells you, oh, I have some catching or locking, there's a previous paper, and now this data, does it really support that mechanical symptoms alone are an indication for doing a hip scope? I think the duration of symptoms more than 18 months is probably a better suitable criteria. So again, patients greater than 25, duration of symptoms greater than 18 months, and then when they have higher grades of dysplasia. And what I mean is when they have a little bit more of a slope to their acetabulum with a tonus angle greater than 15, they had a higher rate. And so if we take these three criteria and add it to the MRI, could we make that decision? And the answer is no. Unfortunately, the MRI is very sensitive, and a lot of things that we see on an MRI that looks like it's a tear does not end up being a tear. So we can't really use MRI as a good criteria. So I'm going to go back and I'm just going to repeat these criteria because these are the things that I would like to use, and I haven't been using them yet because now I'm completing a randomized trial where we're randomizing patients to see whether we can define these criteria a little bit better. But without the randomized trial, these are the criteria that I use to identify patients that I'm going to be doing a hip arthroscopy. And so why not scope everybody? Well, you could, but then you're going to have patients that are not going to be doing anything like I had, or there will be patients where you might end up going through the labrum and then causing more damage. So if you have doubts, and this is a question, if you have doubts about how severe the cartilage damage is, should I scope them? I think that those patients are at risk, though. Those patients, if you go in and dysplastic hip with some cartilage damage and you don't correct their dysplasia, these patients will be in trouble very quickly and will end up with a hip replacement within a year. So you have to have that discussion with these patients as well. So that's for dysplasia. Now, how about acetabular retroversion? So this is completely different. In these patients, those 13 hips that we did, you can see that we did something on every single patient. Almost every single patient had something done. And we've subsequently reported a paper looking at our entire series, and we consider patients with acetabular retroversion to be a completely different, obviously it's a completely different anatomic features. These patients should probably have a hip arthroscopy because the type of damage that they will have is different. It's going to be an impingement of the labrum that eventually tears. Those patients will not get better with the osteotomy alone. Those patients should undergo combined hip arthroscopy and peri-acetabular osteotomy. So how about patients that have had a previous hip arthroscopy? And, some patients with mild hip dysplasia will have that. And usually we think, oh, these patients continue to hurt after their hip arthroscopy is because they have a re-tear of the labrum. That's usually not the case. And I've rescoped patients and I've not rescoped patients after that. So if the patients continue to have pain and they're within 1 year of their initial hip arthroscopy, I will not rescope their hip. I will just do the peri-acetabular osteotomy. And so far, I think that's been a very good option for these patients. Just to give you an example, this is a patient who she was scoped in Vail with that hip on the left, lateral center edge angle of 8 degrees, continue to have severe pain. Even though you can see on the bottom left, you would say, well, that looks like that there's still a tear in that labrum. Well, we thought that because she was within a year, that just offloading the hip with the PAO would be the best option, and that's what we did. And this patient did extraordinarily well. The fact is, she told me that she had less pain 2 weeks after the PAO than what she had the previous 9 months. So how do we do it? So here's a patient. He's a 35-year-old male, bilateral hip pain. He's older again. His tonus angle is elevated. He's had symptoms for several years. He used to play competitive baseball. And so we do the hip scope through our standard hip portals. I try to do it dry initially because I prefer not to have a lot of fluid in the hip scope. But if we have to repair, obviously we start to have to pump some fluid. I really manage low water flow and pressures, because if you use I've had colleagues that use 70 millimeters of mercury for pressure. That's extremely high. It really tightens the thigh. So you want to try to go with very low water pressures. You would do the central hip compartment to manage the labrum. And then if you have a very large cam deformity, then you would want to go into the peripheral compartment. Today, if there's an extremely large cam deformity where I know that the surgery is going to be extreme, they need a T capsulotomy, I may even stage this procedure. I may do a hip arthroscopy initially, and then 4 weeks later, we might come back and do the peri-acetabular osteotomy. I also stage it if I think I need to combine a PAO with, for example, a derotational femoral osteotomy. So when we're doing 2 big open cases, we will do the hip scope 4 weeks prior to. So not all of these are done in the same setting. So here's this patient. You can see the very large hypertrophy. This is a type 3 labrum, hypertrophy of the labrum with a chondrolabral disruption. He's got a round ligament tear as well. So all of these things are treated with the hip arthroscopy. Then he underwent the femoral head neck junction osteochondroplasty. You could close the capsule if you need to, like shown on the bottom right. We did not close the capsule. We don't close it for everybody. You can always put a suture in the capsule once you're doing the peri-acetabular osteotomy. It does give us the opportunity to then do the PAO without taking down the rectus. And like I said, many surgeons can do it now, but when we started, it really changed us from a rectus takedown to a rectus sparing approach, which is what I currently do. And here's this individual 8 weeks after surgery, after his peri-acetabular osteotomy. He did extremely well for years. So in conclusion, I would say that the combined hip arthroscopy and peri-acetabular osteotomy is a very good option. I do think that we still need to define what we need to do intraoperatively. The other point is that you have to be good and quick with both operations. You can't be taking 4 hours to do a hip arthroscopy and then 4 hours to do a peri-acetabular osteotomy. That would be too much surgery. So as you get started with these combined procedures, it's okay to stage them. Do the hip scope first, make sure then you close the capsule, and then come back and do the PAO 4 weeks later. I do think that there's a select group of these patients that will benefit from this combined approach, and that's what we're trying to define. I think that We do have a randomized trial and we'll hopefully be able to complete over the next year. And there's one other randomized trial that's done by the Anchor Group that will also help define the criteria for doing hip arthroscopy and peri-acetabular osteotomy. And I said previously, I do think that retroverted acetabulums need to be scoped or done open, but scope would probably be the best option. And then, as I said again, these two procedures have both the potential of complications. So obviously doing these in a very efficient way will really minimize the potential, complications with hip scope, which is obviously water extravasation and all the other things that can come with the hip arthroscopy, the nerve injuries, etc. And obviously with the PAO as well, it's a very complex surgery. So once you feel comfortable with both operations separately, that's when you should start thinking about doing them in a combined fashion. So thank you very much for your attention. And Dr. Hapa, once again, thank you for your invitation. I'll be happy to take questions, of course.
Thank you so much, Dr. Sierra. Excellent opportunity for us to learn about your technique. Hakan, are there any questions from the?
No, I don't see.
Okay. Then may I ask a few questions, Dr. Sierra? You said you aborted the peri-acetabular osteotomy procedure when there is a contained cartilage lesion, type 4. Do you always abort the lesion when you also see a contained cartilage lesion? For example, you said type 4.
Yeah, so I would abort a peri-acetabular osteotomy if the defect extends very close to the fossa. So for example, I would obviously, these are patients that I have some concern with. Today I would probably be less I would probably not do their hip arthroscopy. I would tell them to probably wait. These patients do very poorly. They have much more pain after that hip arthroscopy than what they had even before. So these patients today, my recommendation is to, if you're in doubt, it's probably best to say, live with this a little bit longer. Once the pain is bad enough, you will need a total hip replacement. So when I have aborted, it's usually patients that, and I've got a model here so you can see. So if you start seeing cartilage damage that goes very close to the fossa, right down here, right? So that means that they have damage all the way on the lateral. No matter how much you correct that, you won't be able to offload that. So in those circumstances, you can see that quite nicely arthroscopically, like that patient that had the microfracture, you could see the fossa there. It was very close to where the hip was. And in those cases, I would abort and decide not to do it. But again, just to reemphasize that selection is probably more important. And you can see these, I mean, the problem is that they're usually young patients. So I remember every patient has been a woman between the age of 31 and 33. So they're young, they're thin, they're athletic, and you look at the x-rays and you look at the MRI, it's like, ooh, this may not look good. And, I would prefer today to simply say, live with this a little bit because you're going to be worse off.
Okay, thank you so much. Thank you. And you said when there is chondrolabral junction separation in dysplasia patient, you said it is better to scope and repair the labrum, I think. But there is no way to understand it preoperatively, I think, from MRI or
yeah.
Do you still say if there's type 3 tier chondrolabral junction separation dysplasia patient, we must repair the labrum?
Yeah, that's my indication intraoperatively for repair. So if I see a chondrolabral disruption, I will repair. On the MRI, it's very hard to see a chondrolateral separation unless there is detachment from the capsular side as well, and you have a bucket handle tear. If you have a bucket handle tear where it's completely detached, and you can see that, you can see it. But when there's only chondrolabral separation, it's still attached to the capsular side, and you can't detect that on MRI. So the fact is, we went back and we looked at these same patients, reviewed their MRI findings. We had our radiologist read them separately. Again, he was blinded to our intraoperative findings, and our correlation was only about 50%.
Oh, yeah.
And the correlation is about 50% because MRI tends to overread the tears. It wasn't the opposite. It wasn't like they were not seeing a really bad tear. They were identifying something as a tear that did not to be fixed. So why did it not be fixed? Because sometimes there will be some intralabral, signal change that you're not really put a suture inside the labrum. You're only going to be repairing the ones that are detached from the rim or when there's separation. But you won't, but you can see some signal changes, and those signal changes don't need to be repaired.
Okay. So one last question. Sorry about for the.
No, I'm okay. You take your time.
No, this is the last question. I don't want to bother you. So few words about the most questionable issue, borderline dysplasia and impingement, for example. Can you put a light for us, for inexperienced surgeons? What do you do, for example? Treat the dysplasia first, or whether it is impingement? Can you say, for example, you told me ROM, range of motion of the hip, is very important. I try to keep at least 20 degrees of internal rotation. Can you say a few words about the more gray zone, borderline dysplasia and maybe impingement?
Yeah, so that's a great question. That's a great question, and I don't think we have the best way to answer that. So I will start by saying that obviously we focus a lot on the amount of under coverage, right? So obviously we have to grade it somehow, and we usually say, okay, so if somebody has less than 18 degrees of lateral coverage, then that's no longer borderline. But borderline would be somewhere between 18 and 28, or that would be mild hip dysplasia between 18 and 28. And that becomes somewhat of a moving target, right? Because it depends on obviously the patient's range of motion. So if a patient has borderline coverage of the acetabulum, but they have a large cam deformity, and they have abnormal range of motion, it's unlikely that that hip is unstable, right? It's unlikely. It would be very unlikely that the patient would have instability in the hip unless they have posterior instability, which is meaning the hip comes up and then slides posteriorly. That's different. But from a dysplastic standpoint, it would be very unlikely that a patient that has limited range of motion would have instability. So the majority of those patients are males, right, that have borderline coverage of the acetabulum. Here in the US, many of them are athletes like hockey players or soccer players. Some of these patients will have those kind of features. That's very different from the patient that has an unstable hip. Let's call it an unstable hip or instability, which is a patient that has the same coverage, 18 to 28, does not have a cam deformity, and has excellent range of motion, because sometimes they have also increased femoral anteversion. So those patients are those that we would consider to be unstable or have a degree of instability. And so these two patients could be treated completely different, right? Many surgeons consider the patients that have impingement, right, the patients that should be treated arthroscopically first and see how they do. The problem with that is that the dysplasia will catch up to the patient at some point. They may have impingement now, but their dysplastic hip will lead to edge loading and they will also cause damage to their hip through the dysplastic way of causing damage, which is with rim overload. And how do I know that? Is because when we looked at our natural history study, where we published this in 2018, it was a winner of the Charnley Award for the Hip Society, we found that patients that had impinging and dysplastic hips were the worst actors. They did the worst. They were the ones that had the early advanced degenerative changes, the ones that needed hip replacement at a very young age, all those things. And the reason behind that is because when you impinge, you damage the rim. And if you already start with a rim that's not perfect and you damage that rim, then that hip is even worse. So you damage the rim that is dysplastic, and then it ends up being more dysplastic from a functional standpoint. So I do think that if you have an extremely young patient and you want to correct all the features of their hip, even if you start with an impinging process initially, which is the cam deformity and the dysplasia, and treat it, you will eventually have to treat the dysplasia, and you may have to treat it fairly aggressively. So let's say I have this patient here. So this is a patient here. I don't know if you can see it. Like, they've got impingement, right? I'll do the femoral head neck junction osteochondroplasty, and the hip arthroscopy to repair the labrum. But in some of these patients, if you want to treat all their problems, they may have to have the PAO either in the same setting or staged 4 weeks later. And, some patients need a derotational osteotomy as well to maintain their range of motion. So those are obviously procedures that are extreme procedures, a lot of surgery. But sometimes some of these young patients that have the combination of hip impingement and dysplasia will need to save their hip.
Okay, thank you. Thank you so much again, Dr. Sierra. We bother you so much. Thank you again for this excellent seminar on about and mostly untouched topic. Great to meet you. See you
And
again.
can I ask you a couple questions? So, is hip arthroscopy growing in Turkey?
Yeah, sure. We have a hip preservation society, and I did 3 or 4 hip arthroscopy fresh cadaver course, and the society did a recent cadaver course 2 days ago in Istanbul, and yeah, hip arthroscopy is growing. But peri-acetabular, I think I would like to repeat your technique that you told me when I visit you. You said, I think most of the surgeons don't know in Turkey, you said for isolated lateral coverage, you must do isolated lateral rotation. This way of correction, abducting the fragment or adducting the fragment, you said only increase the amount of retroversion or anteversion.
Yeah.
For main coverage, for example, the black point on the shunt screw must rotate laterally, and symphysis pubis must get up, and the hot surface of the iliac wing with upper surface of the iliac wing must be parallel. You said this is a very great trick you taught me for isolated lateral coverage instead of increasing the retroversion. This is a very great trick you taught me. Thank you so much again. And one last thing, you said lateral center of AJ angle is not important during peri-acetabular osteotomy. You must get flat tonus angle, medialize teardrop, and under coverage is always better than over coverage. Over coverage, you said, Dr. Sierra. Am I right?
You're right, especially in the patients with mild hip dysplasia.
Mild hip dysplasia.
if you overcover the patients with mild hip dysplasia, they will not stop bothering you the rest of your life.
And internal
Yeah.
rotation is must be minimum 20 degrees. Rotation is so
Yeah, you
important.
want to maintain a functional range of motion always. So if you, I mean, and this is what sometimes you have to anticipate that you will lose more. So you have to talk to patients about potentially doing derotational osteotomies and things like that if you're not getting. The other feature that you can't ignore is that sometimes always look for the degree of femoral, the degree of acetabular version that the dysplastic socket has. Because
Yeah.
if you have a hip that has acetabular retroversion in addition to the dysplasia, those are hips that may have decreased range of motion initially, but they will end up with about the same range of motion by simply anteverting the fragment in addition to lateral coverage. So those worry me less than those patients that don't have retroversion and have limited range of motion initially, because those patients will tend to lose range of motion.
So one last thing, you said anteverting PAO is not reverse PAO. I learned wrong from the burn. I understood wrong. So you said to decrease lateral center of age and to decrease over coverage, it is the reverse peri-acetabular osteotomy. And do you, for example, treat protrusio or profunda patients with reverse peri-acetabular osteotomy?
Yes, I
When
do.
the head is, for example, touching the ilioischial line, can you treat them with reverse peri-acetabular osteotomy, Dr. Sierra?
You can, but it's not. You can't do it alone. You have to do it combined with a surgical hip dislocation. So this is a combined procedure. So obviously the PAO will do. The PAO will help with. Let me get off my blur. There you go. That's better. So with a PAO, so let's say this is the false profile view. I think you can all see that here. This is the false profile view. So this would be the AP view like this. So you can reverse, meaning you can take a tonus that's negative and make it normal by a true reverse. So instead of with a dysplastic hip, you're causing lateral coverage. With these protrusions, you tend to correct the downgoing sourceal to a more normal position. But when you do that, you tend to have, obviously you rotate around, you will have the ischial part come into the joint. It'll come into the joint, and then the patients will impinge in adduction. They will impinge when their hip is brought into this position. They're going to impinge down here because you've taken that socket and done this to it, right? So they will impinge down below. So you have to do a surgical hip dislocation to trim the anterior posterior rim of the acetabulum, not touching the superior border, just the anterior and posterior, and then to take the bone from the inferior aspect. So, so that's how you would treat. But even then, that's a good operation for a coxa profunda. If you have a true protrusio, I don't know if we have a good solution for that. My experience with true protrusio has been bad. I mean, I'll do that operation and then patients come back, they still have poor range of motion, they'll still impinge, and I've had to replace a couple of my patients' hips fairly early because they still unhappy.
Thank you. Thank you so much, Dr. Sierra. And hope to meet you in IZMIR at our hip meeting at a closed day. And it's very warm greetings to your family. And thank you so much again for your hospitality, for your Thanksgiving dinner. Thank you so much for everything. I learned a lot. Do you have any questions or do you have any additional things to say, Dr. Sierra?
No, I'm good. Thank you again for the invitation. And if there are no further questions from the Zoom audience, then
Hakan, is there any questions on the YouTube?
No, I don't see.
Okay, thank you for sparing time. We learned a lot again. It was a great contribution to our community, Turkish orthopedics
Okay.
community.
Thank you. Okay. Thank
Bye.
you. Bye-bye.
Bye bye. Warm greetings to your family. Thank you.
Thank
so
you.
much.
You too.